PP2A inhibition PD-1 blockade with LB100 and dostarlimab in ovarian clear cell carcinoma.
Thank you. Short people problems. I will be discussing investigational uses. I have no disclosures. Clear cell ovarian cancer is a rare histologic subtype often associated with platinum resistance. This chemo-resistant behavior has motivated exploration of alternative treatment regimens. Previously, our group evaluated dual checkpoint blockade in patients with ovarian clear cell carcinoma and found that a subset of patients with mutations in the PPP2R1A gene experienced a significant increase in overall survival, as shown here on the left. PPP2R1A encodes the scaffold subunit of PP2A, a serine threonine phosphatase that serves as a major tumor suppressor. In a subset of patients, hotspot mutations in PPP2R1A impair enzyme assembly and reduce PP2A activity. Based upon these findings, we sought to understand whether pharmacologic induction of the PPP2R1A mutant phenotype could enhance efficacy of anti-PD-1 checkpoint inhibition. We conducted a phase 2 single-arm study in patients with recurrent ovarian clear cell carcinoma with wild-type PPP2R1A. Patients were treated with dostarlimab plus LB100, a PP2A inhibitor. The primary objective was to estimate overall survival. In terms of cohort selection, key inclusion and exclusion criteria are provided here. In addition to excluding patients with mutant PPP2R1A, which is found in approximately 10% of ovarian clear cell carcinomas, the study also excluded individuals with dMMR or MSI high tumors. The cohort had a median age of 61 years and had received a median of 2 prior lines of therapy. At the time of data cutoff, 5 of 21 patients remained on study and the median follow-up length was 12 months. A median of 5 cycles have been administered, though the range was broad from 1 to 28. The combination has thus far had acceptable safety. There was 1 grade 4 lipase elevation, but no grade 5 treatment-related adverse events. At the time of data cutoff, median PFS was 2 months, however, median OS has not been reached. In considering ctDNA dynamics, we found that the best response by ctDNA corresponded with survival outcomes. Among patients whose ctDNA increased from baseline, the PFS was 1.9 months versus 13.5 months in those whose ctDNA declined. Similarly, OS was 10.1 months versus not yet reached. In terms of efficacy, the objective response rate was 30% with a median duration of response of 11.7 months. Disease control rate was 40%. Additionally, we identified a statistically significant correlation between clinical benefit and the presence of a TERT promoter mutation. Based upon the findings of this cohort, we have opened an expansion cohort of an additional 21 patients to evaluate a regimen with increased exposure to LB100. The dostarlimab dosing will remain unchanged, however, LB100 will now be administered on both days 1 through 3 and 8 to 10 of each cycle. We hypothesized that additional mid-cycle dosing could increase target engagement and better approximate the immunobiology of PPP2R1A mutations that may underlie sensitivity to immune checkpoint blockade. Thank you. I'd like to thank in particular my mentor, Dr. Amir Jaziri, and the site PI at Northwestern, Dr. Emily Hinchcliffe.